Good afternoon. Should we start or you want to wait for him?
That's good. I just have an announcement.
Okay, why don't you go ahead.
So just a reminder that we have no grand rounds next week for April 11th. It's oral exams. And then the following Wednesday, April 18th, there again are not grand rounds, but there is departmental training on Title 36. An email just went out about that. So it's close to the community, more or less, but there's an email about that. Okay? Thanks.
Thank you. I'm very happy to introduce Dr. Kishore Sriram today. He's the speaker. And he will be talking on suicide risk assessment in children and adolescents, which is an important topic. Before I say a few words about him, I should tell you that he has nothing to disclose. So we have done that. Dr. Sriram, he's originally from India, and he did his medical degree from Armored Forces Medical College in Pune, which is really excellent medical school in India. And then he did his rotating internship there, and then he did house job in psychiatry. And then he came to USA, and he did the master's in early childhood disorders and child psychology. And then he joined general psychiatry residency in St. Louis University, which is also excellent university. I was in St. Louis, so I can tell you that. And Dr. Sriram has been outstanding fellow. He's in second year. What I can tell you, he's a very nice gentleman, compassionate, hardworking, caring. I can go on, and I think people who know him, they can, confirm that. Thing is, around this time when fellows start presenting, we start thinking about graduation, and which is a kind of excitement, but also about residents and fellows leaving. And I'm not sure I'm ready for his leaving. I wish he could stay in Arizona, but he has to go for his J1 visa waiver, he's going to Indiana. And I guess we'll keep on wishing him well till he leaves. I was supervising him last year. At that time, he was trying to figure out what research project he wanted to do. And we were talking about, suicide assessment in children and adolescents. What is essential? Are we doing comprehensive assessment? What are some of the questions which should be addressed? And are we doing that at the University of Arizona, UMC, when we provide consultation or in outpatient? So he decided to do a project on that, and I'm glad that he did. And I'm sure you like to hear about his project, and I would like to hear too what are his findings. Thank you, Dr. Sriram. Welcome.
Thank you, Dr. Guman, for your nice words. And I want to welcome you all, and also thank you for everybody like joining me today for this presentation. Today, my topic of discussion is suicide risk assessment in children and adolescents. Youth suicide is a major mental health problem in the United States and also elsewhere in the world. A lot of progress has been made in this area, especially in assessing suicide and also kind of raising the public awareness. But however, still only 50% of the suicide completers are in treatment, 50% are not. So there is still a lot of work that needs to be done in this area. And early on in the 19th century, for the first time, youth suicide was recognized as a problem in Europe after a book was published. The name of the book is The Sorrows of Young Werther. This is a romantic classic which was written by Goethe. In this book, the book's hero commits suicide at the end because of a lost love relationship. Following this publication of this book, there has been increase in youth suicide. It was like an epidemic. So in those days, they had to ban this book in Europe, thinking that this book was the cause of this epidemic. And actually in 1910, Vienna's Psychoanalytic Society convened a meeting, almost like emergency meeting, to evaluate youth suicidal risk factors. And these are the early stages where youth suicide was recognized. In the United States, there has been a rapid rise in youth suicide in 1960s, mainly late 1960s, and it peaked in 1977. However, in the following subsequent years, there has been decrease in rates of youth suicide. Youth suicide was not recognized in the United States until 1980, which led to the public uproar and led to various programs, including many school programs, which have shown like they are very effective in increasing student awareness and to promote treatment-seeking behaviors. When we actually look at the rates of youth suicide, we can see among 5 years to 14-year-olds, the rates are 0.6 per 100,000, and among 15 to 24-year-olds, it is 9.5%. There is a substantial increase when kids transition from childhood to adolescence. This rise can be explained by when in adolescence there is an increased prevalence of psychopathology, increase in mood disorders, increase in substance abuse, increase in comorbidity, which leads to this increased rate. And also, especially, young children are not mature enough to make a complicated plan and to carry out a complicated plan. So they are not cognitively mature enough. But adolescents, on the other hand, they can make a plan and they can carry through the plan. And this is also part of the reason why there is increased rate in adolescents. For all ages, the suicide rate is 10.5 per 100,000. And suicide, some facts about suicide is, this is the third leading cause of death in 15 to 24-year-olds, only preceded by accidents and homicide. This is the fifth leading cause in 5 to 14-year-olds, and 11th leading cause for all ages. This is a graph from CDC, which shows the difference in race and gender. This is about completed suicides. So we can see, when we see the gender, in general, females have lesser rates of suicide completions than males. This is partly because males have multiple comorbidities and they are at increased risk of having mood disorders. They are also high incidence of alcohol abuse or drug abuse, and they also choose more lethal methods to commit suicide. On the other hand, females attempt suicide more, and they also report suicidal ideations more than males. When we look at the races in the United States, we can see Native Indian or Alaskan natives have highest rate. It almost reaches 27% in males, and which is followed by Caucasians, non-Hispanic white, followed by African Americans, followed by Hispanic. Especially among African Americans, recently the rates of suicides has been increasing, and they think it is probably due to loss of traditional cultural values. When we look about the Hispanic males, they tend to follow a little bit of female trends. They report suicidal ideations more, they attempt suicide more, but completed suicides are very less. And in Asian population, you can see the rates too. It is lesser than other cultures. And this is also from CDC. These are the percentages of US high school students who are considering, planning, or attempting suicide in the past 12 months. And this graph is from 2007. You can see almost 18% of the females have considered suicide, which is a very high number, versus to almost maybe 10%, a little higher than 10% in males, and actually 13% of females plan suicide versus maybe 9 to 10% of males, and actually 9% attempted suicide versus 4.5% in males, which is exactly half. So this establishes that youth suicide is an important public health problem, and this needs to be addressed. And especially in a university setting where there are residents, there are fellows, and there's a consult liaison service, suicide risk assessment is the major part of the work that the consult liaison service does. There are not many reliable scales available to assess youth suicide risk. However, there are few, and there are very good scales. One is Columbia's Suicide Severity Rating Scale. However, using these scales, it is difficult to tailor treatment specifically to the needs of the kids. It can assess the risk well, but looking forward to the treatment and treatment settings, it's difficult to assess with these scales. So many psychiatrists do follow traditional clinical assessments. And so we are going to talk more about the suicide risk assessment. And suicide risk assessment is not an intuition, it's not a guess. It is establishment of clinical judgment of risk in the near future. It is a systemic process, it is structured, and it involves comprehensive interviews with youth and their parents. This is very important because we not only need to interview the kids, we also need to interview the parents, and we need to get collateral information. As many of you have seen, when we go to the ER, we have a consult, we go to the ER, they say that this kid might have attempted suicide, this had suicidal ideations. When we go see them in the ER, this kid is sitting on the bed, he's watching cartoons, he's kind of like happy. When we get the history, when we get the collateral history, we see that there has been deterioration in the past few weeks or few months. There's been increase in irritability. There has been more depressive symptoms that are observed. But many of the kids, they don't like hospitalization. They might tend to deny the symptoms. So it is always important to get collateral information. And especially while evaluating kids, it is important to interview the kids separately from the parents. This has more clinical significance. And suicide risk assessment also involves specific suicide inquiry and also determination of risk, which is low, moderate, or high. So how do we determine the risk? So we do a psychiatric examination, we evaluate the risk factors, we evaluate the protective factors, we see if the risk factors are modifiable or not modifiable, and we also inquire specifically about suicide, and we determine the risk. For understanding or evaluating the risk of suicide, it is important to understand suicide is a multifactorial event. It depends on so many factors, so many variables. One of them is, major important thing is psychiatric illness or comorbidity, current symptoms, familial factors, stressors, psychological factors, family history, genetics. So what are the areas to assess? We typically assess for any psychiatric illness, affective disorder, substance abuse, conduct. We also evaluate past history of suicide attempts, past psychiatric history, past self-harm behaviors, family history of suicide attempts or mental illness, and we also look for any medical diagnoses that are comorbid. We also assess for individual strengths, vulnerabilities, psychosocial situation, and specifically the suicidal symptoms. Talking specifically about psychiatric disorders, this is a table from multiple studies, and in these studies, these are mainly studies of suicide completions. As you can see, the age range in these studies is mainly pre-adolescent, just around puberty, adolescents, and young adults. Mainly, you can see it is mainly the adolescent age. And if you see the psychiatric diagnosis, majority of them have a diagnosable psychiatric condition. Almost 90% has a diagnosable psychiatric condition. When we look at the mood disorders, it actually ranges from 45 to 75. Among the mood disorders, they specifically looked at major depressive disorder, which actually ranges from almost 32 to 54, except in one study which had 15. But the N value is also, except one study. And mood disorders, or MDD, this MDD did not take into account depression NOS or dysthymia. It's just the regular diagnosis of MDD. This is closely followed by substance abuse. Conduct disorders had an increased rate. ADHD has increased rate due to possibly impulsivity. When we look at rates in schizophrenia, we see the rates are much lower than adult populations. This is possibly because the first episode of psychosis usually occurs in the late adolescence to young adulthood. So possibly diagnosis of schizophrenia has not been made in this population. When we specifically speak about affective disorders, mood disorders contribute substantially to the risk of suicide. Rates of MDD, as we just seen, it ranges from 32 to 54, and current major depressive episode increases the suicide risk by 27-fold. And approximately 1/5 of suicide completers were diagnosed with bipolar disorder, and the diagnosis of bipolar disorder increases the risk by 9-fold. Mood disorders are closely followed by substance use. Substance use increases risk of suicide substantially, and especially when it is comorbid with mood disorders or disruptive disorders, the rates are much higher. However, most of the studies in the United States showed substance abuse to be a major risk factor primarily for males. However, there was one study in Finland which showed similar rates in both males and females. And suicide attempters are more likely to have substance abuse or substance dependence than from suicidal ideators. So maybe possibly implicating that substance abuse may facilitate this transition from suicidal ideation to suicidal behavior. When we really think about it, so substances generally cause people to be more impulsive, compounded by disinhibition caused by substances, and also altered consciousness. This might lead to a completed suicide. Disruptive behavior disorders increase the risk by 3 to 6-fold in youth. And there has not been a clear-cut association with anxiety disorders, however, when controlled for mood disorders and other conditions. However, panic symptoms seem to raise the risk substantially. Especially in some adult studies, it has shown that it raises the risk by 20-fold. And there has not been a clear association with post-traumatic stress disorder. In one school-based study, there was increase in risk of suicidal ideation and suicide attempts after controlling for other factors, especially depression and gender. And even with the eating disorder, it is not very clear-cut. However, patients with anorexia nervosa who have attempted suicide have average mortality 8 times higher than rest of the general population in 14 to 25-year-olds. And psychiatric comorbidity seems to be an important risk factor too. There is an increased risk of like 70% if they have multiple comorbidities. With the increase in number of comorbidities, the risk increases substantially. And this risk is for suicide completions and also for suicide attempts. And when we look at the comorbidities combination, mood disorder, disruptive disorder, and substance abuse in combination seems to be the worst. So after we spoke about a little bit about psychiatric disorders, it is important to kind of like maybe know a little bit about the profile of suicide completers. It is important to know that suicide occurs early in the course of the illness. Risk is higher in the months following hospitalization. So it is actually a month leading to the hospitalization and a month after hospitalization. If you really think about it, most of the times we get a report of worsening of symptoms at least 1 week or 2 weeks or 3 weeks prior to the hospitalization. Then we hospitalize, we stabilize the patient, we kind of like provide support, and we transition to the outpatient. And transitioning to the outpatient, we are actually sending the patient back to the psychosocial stresses where they actually came from. So there is an increased risk after hospitalization. And as we discussed, panic symptoms seem to increase the risk. Substance use, moderate alcohol abuse, first episode of suicidality seems to be very important. And also males are at a higher risk than females, except for bipolar disorder, where the rates are similar. When we look at the psychological factors, personality disorders, especially in psychological autopsies, showed like 1/3 of suicide completers do have a personality disorder. When we think about it, most of us might have faced with the difficulty of differentiating self-harm behavior to suicide attempt. And if there are more self-harm behaviors, there is a chance of an accidental suicide. Or these repeated self-harm behaviors might make the person less sensitive to these behaviors, and actually, due to the impulsivity, they might actually complete a suicide when there are severe thoughts. And when we looked at the cluster B population, there is an 8.5-fold increase for cluster B personality disorders. And we should exercise extra caution while evaluating for these patients with chronic self-harm behaviors. Impulsive aggression is a tendency to react to frustration or provocation with hostility or aggression. This trait has been linked to suicidal behavior. It has been found that in individuals with impulsive aggression, there is low levels of CSF 5-hydroxyindole acid, which is a metabolite of serotonin. And this finding has been replicated in multiple studies implicating the role of serotonin in suicidal behavior and also impulsive aggression. This neurobiological factor is actually transmittable. It is implicated in the familial transmission of suicidal behavior too. There are not many studies which looked at neurobiology of suicide in youth. And speaking of familial transmission, in molecular genetics, they looked at the tryptophan hydroxylase gene, and they recognized 2 alleles which are implicated in suicide behavior. One is a U allele, and one is a L allele. L allele confers more risk. If there are 2 L alleles, the risk is even much higher. And various other psychological factors have been looked at, especially impulsivity, self-esteem. However, when other factors are taken into account, like mood disorder, substance abuse, they did not find any association for impulsivity. No, they did not find any association for self-esteem, I'm sorry. Neuroticism is a personality trait characterized by tendency to experience more prolonged and severe negative affect in response to stress. And this trait is linked to youth suicide attempts. And it had a strong discriminative power in case control studies associated with family suicide. And in one large birth cohort study, it predicted eventual suicide attempts even after controlling for significant other factors. Other factors that have been looked at are hopelessness, perfectionism, sexual orientation, and when actually looked, when it is controlled for mood disorders and substance use, they did not find any increased risk specifically for these psychological traits. And past psychiatric history seemed to be very important. Past suicide attempt is the single most potent predictor of youth suicide. It elevates the risk substantially, 10 to 60-fold, and the risk of repetition is highest in the 3 to 6 month period after a suicide attempt, and it remains substantially elevated for at least a period of 2 years. And relatives of adolescent suicide completers have a 2 to 6-fold increased rates of suicidal behavior, even after controlling for high rates of psychopathology in these relatives. And when they actually looked at offsprings of mood disordered attempters versus offsprings of mood disordered non-attempters, there is a 5 to 6-fold increase rates in offsprings of mood disordered attempters, even after controlling for other factors such as depression and other psychopathology. And if there is a familial loading for suicidal behavior, if there is a greater familial loading, it is associated with higher risk and earlier onset of suicide attempts. So it implicates that early onset suicide attempt may be particularly familial. Other family factors, the important factor in youth is parental psychopathology. Parental depression, substance use, antisocial behaviors are risk factors for attempted and completed suicides in youth. When we really think about it, parental psychopathology plays a very important role in psychological development and also development of psychopathology in youth. And suicide completers tend to come from non-intact families. However, I want to clarify that the relationship between divorce and suicide behavior is explained mainly by the increase in psychopathology in the parents whose marriages actually ended in divorce. I think this relation is indirect rather than a direct relationship. Divorces does not increase suicides, but it is indirect that parents have psychopathology which increases the rates of divorce and which also increases the rates of suicides. And I also want to impress upon you, it is the quality of the parent-child relationship that is important rather than intact families or non-intact families. And several studies have found that loss of a parent to death, to divorce, or separating from one or both parents has a significant risk for completed suicide. It need not be a parent. Sometimes it can be a loss of a friendship. It can be a loss of relationship. This can increase suicidal behavior. And in one study done by Levinson and his associates, they found that loss of a parent prior to the age 12 had increased significance for multiple suicide attempts later in the life. And they also found that persistent traumatic grief has a 5-fold greater likelihood of suicidal ideation after controlling for depression and after controlling for depression. I remember a case when I saw in the ER. This was almost like 6 months ago. This is a 14-year-old Hispanic girl who came to the ER after a suicide attempt. So when I took the history, it seemed like parents of this girl are illegal immigrants from Mexico, and the kids, there are 2 kids, like one is a 14-year-old girl who is a patient and there's a 10-year-old boy. But they are currently citizens of the United States. However, this family got into the immigration battle, and the State Department cut them a deal saying that one of the parents can stay with the kids for their education here in the United States on a specific kind of a visa, and one of them had to be deported. So they chose, dad was deported. And this girl since then developed she was missing dad, she was getting a little bit socially withdrawn, was depressed. However, she was doing fairly well academically. And 2 years later, in 2 years, the family tried to reunite, but it was unsuccessful. 2 years later, on dad's birthday, this girl attempted suicide, by overdose and pills, with the hope that she's never going to get back with the dad. So she was kind of a little bit hopeless. And you can see there is no death in the family in this case. However, just parental separation was kind of enough and this traumatic, prolonged grief of losing a parent actually led to suicide in this case. I'm sorry, it was a suicide attempt. And as I discussed earlier, quality of the parent-child relationship is important. And some studies have found that poor communication with the dad had a significant risk. I'm not really sure why they found specifically with the dad, not with the mom, but that's the finding. And it's also important that perceived parental support, lack of perceived parental support is an important risk factor. On the other hand, family cohesion, positive parent-child connection, parental supervision, high parental academic and behavior expectations were protective factors. So kind of like it implies that parent being involved in child's life and child being involved in parents, in the family or in school seems to be a protective factor. And we all know that physical and sexual abuse increases the risk of suicide. Especially, it is mediate, like abuse in the early stage is much more complicated. It not only affects by increasing the psychopathology, but it also has an independent effect on suicidal behaviors. So, and when we speak of intergenerational abuse, the risk is even more higher. When the parents are abused, it increases the chances that these parents are going to abuse their children. So it not only increases the chances of abuse, it also increases the chances of suicidal behaviors in these offsprings. And so intergenerational transmission of abuse is very important, and it's a good history to get. Connectedness or being involved is a protective factor. It could be with school, it could be with the family, in friendships, relationships, and other support systems. Being disconnected from the support system seems to be a major risk factor in the context of other risk factors which actually led to the drifting status. As we see, there are more suicides in school dropouts. And also, there is a positive connection to school and academic achievement that it is protective. Other stressors are legal problems. Many kids we see in the ER and elsewhere in the community, in the agencies, many kids do have legal problems, and legal problems do increase the risk of suicide. School problems seems to be a major risk. Bullying, and especially when we think about bullying, recently a young adult in New Jersey actually committed suicide because of cyberbullying by his roommate, and it's been in the news recently. Humiliating events can lead to suicidal behaviors too. So we kind of like gone through psychiatric risk factors, psychological risk factors, stressors, familial stressors, genetics. And the last part about suicidal inquiry is, suicidal assessment is specific suicidal inquiry. Suicidal ideations are important to assess. Suicidal ideations are thoughts of harming oneself or thoughts of killing oneself. So it might vary in severity. It might be passive suicidal ideations to specific suicidal ideations with intent and plan. And intent is the extent to which a suicide attempter wishes to die. So when we are assessing for suicidal ideations, intent and plan, we need to give special consideration to suicide attempts. It might be actual suicide attempt, or it could be an aborted suicide attempt. Aborted because the kid did not carry through even, but because he was scared, or because he was discovered, or he communicated to someone else, and maybe they talked him out of it. So it is important to get that history. And first episode of suicidality seems to be very important. Always pay attention to the hopelessness. As we discussed in the case of the Hispanic girl who was separated from the father, she did not have any hope of reuniting with the father. Ambivalence, wish to die or wish to live, is a very important thing to know about because it gives us a chance to intervene. And also, it's important to get psychological pain history, especially in kids who are abused, or they might be going through multiple stressors, financial. And what are the characteristics of a suicidal plan? We speak of a suicidal method and suicidal lethality. Lethality of the method. Lethality is an objective danger of life associated with suicide method or action. So less lethal plan doesn't mean less suicidal intent, especially in younger children, because they are not cognitively mature enough to make a concrete plan or go through a concrete plan. And so planning involves preparation before the attempt. We have to kind of it's important to know about how they are planning the attempt. Maybe they bought a rope, they borrowed a gun, or they kind of like are timing it so that everybody sleeps. And they also, it's important to get how are they preventing the discovery. Maybe they want to commit suicide when everybody else is sleeping in the house, or the parents are not in the house. And it is important to know about it. And communication. Many suicide attempters do communicate with friends and family. Many times we hear in the ER that like the kid overdosed on pills while everybody else is sleeping, and maybe a little while later they texted the friend, and friend actually called to wake up the parents and alert them. So also look at the communication part of it. And motivation is the reason given by the patient or the family for the suicidal act. So when we look at the suicide methods in the United States, this is also a graph from CDC. When especially this is a graph like that differentiate males versus females in 10 to 24-year-olds, especially in males, we see almost 50% of suicide completers have chosen firearms, and almost 30% by suffocation, and there is very little poisoning and fall and other factors. When we look at the females, firearms contributed to only 30%, and the 40% is suffocation, 20% is poisoning, and the fall and other factors. It is also important that like to know the lethality of the attempt. Firearms are highly lethal, suffocation is highly lethal, and also fall is highly lethal. And suicide method also seems to go by culture of the city, or culture or religion where they live by. Especially when we see in like San Francisco, there has been many suicide completions by jumping off Golden Gate Bridge. And in the case I just discussed, where the young adult committed suicide after a bullying, he actually jumped off the Queens Bridge in New York. And while evaluating for suicide, also look at degree of ambivalence, as we discussed. Wish to live, wish to die. This gives us a chance to intervene. Also evaluate the intensity and frequency of the suicidal thoughts, of the suicidal ideations. Look at the rehearsals. So you'll be surprised how many youth or how many adolescents, they rehearse suicide. There was one girl specifically, I remember, in a period of a week, she tried to overdose on Tylenol, 6 pills of Tylenol at first. It did not work out. Then she actually tried to 15 pills of Tylenol. Then she later did some research, and like a week later, she actually took 25 Tylenols. 1 hour later, she texted a boyfriend. Actually, boyfriend was breaking up with her. She texted a boyfriend who actually alerted the parents, and she ended up in the ER. So there might be rehearsals of suicide. We definitely need to keep an eye on that too. And also make sure that we document the method and also availability of the method. Especially this is very important for firearms. We have to follow gun safety. We have to, if there is a gun in the house, they should lock it up. Then kids should not have access to the guns. And also look for the presence or absence of a suicidal note. And also evaluate deterrents. So if there are any protective factors, if there might be positive relationships, maybe positive therapeutic relationship with a therapist or a doctor, positive support system, school, work, anything. Sometimes religion can be protective too. So after we evaluate all these risk factors, we come to a conclusion based on our clinical judgment if it is like high risk, low risk, or medium risk. Also, especially in a university setting, it is important to seek consultation and also supervision, especially in our setting with the CRC opening. Kids go to CRC, somebody at CRC evaluates and deems that they need level 1 placement. After 23 hours, they are transferred to EMC ER because they cannot stay more than 23 hours in CRC. And they come here waiting for level 1 placement. Parents get frustrated. Most of the children don't want to go to the psychiatric hospital, so they kind of like change their story, and parents feel much more comfortable that they've been with the kid for almost 23 hours. Now they feel they can take the kid back home. So when you go and evaluate in such cases, it is very important to get information from the previous provider who thought level 1 is necessary. And also, suicidal thoughts wax and wane. So it is important to assess and reassess at different points of time. Especially this is important in inpatient and also in outpatient. So once we are done with the suicide risk assessment, we tend to plan for the treatment or tend to look at the setting. So top priority is the patient safety. No matter what the patient wants, no matter what the family wants, we should look at the patient safety first. And also, we need to assess for the treatment plan and the treatment setting. Not everybody who is suicidal needs to go to a level 1 facility. Sometimes level 2 facility can be more helpful than a level 1 facility, especially in chronic suiciders or chronic suicide attempters. Level 2 facility can be more effective, providing therapy, providing support, and facilitating the family therapeutic aspects of the treatment. And we also, sometimes we discharge patients if the suicidal ideations are not intensive, or we can send them home with the intensive therapeutic follow-up. So we need to assess for the treatment setting. We have to decide upon the somatic, like whether we are going to provide any somatic treatments like medication management, or we are going to go with the intensive therapeutic follow-up. However, there is limited data on the evidence of psychotherapy being effective in acute crisis states. And also educate the family, educate the patient. You have to educate them about like how suicidal ideations occur. They wax and wane, and they increase with stressors. They, with the psychiatric symptomatology, they also kind of like to increase or decrease based on that. And also importantly, many times when we say to the parents that we are going to hospitalize their kid, we are sending their kid to a psychiatric hospital, they get scared. I mean, they don't know what to expect in a psychiatric hospital. They have seen like horror stories in movies. So it is important to educate the parents, educate the kid about like what to expect in a psychiatric facility, what is a psychiatric facility like, and how will they be transitioning from inpatient to outpatient. Many times, like when we say to the parents that we are hospitalizing the kid, they are scared, they don't want it, but when we actually go through this process, actually many times parents would agree with hospitalization. And also, monitor the psychiatric status and response to treatment, reassess the kid always. Especially this is important in inpatient facilities. Coming to suicide contracts. So, suicide contracts, they have problems, and they have some, maybe not advantages, they have some possibilities. These suicide contracts are commonly used, but however, there has not been any demonstrated ability to reduce suicides. It is not a legal document. Even if it is signed or not, it doesn't stand a chance in court. It cannot be used instead of a psychiatric evaluation. So what are the possibilities? It is useful when there is a positive therapeutic alliance with the therapist or the psychiatrist. But however, when you're covering for a colleague in an outpatient setting, you cannot use psychiatric contracts because you don't have a therapeutic alliance with the patient. It doesn't seem to be effective. And if suicide contract is employed, outline the terms of contract in the patient record. This is important. And Also, it is useful when you emphasize the availability of the clinician. So, patient should know how to get in touch with the therapist or the psychiatrist, and especially pay attention when somebody says, "I don't want to sign the contract." So they are trying to tell you something. It's good to explore what they mean by it. I mean, what are the motives behind that? And the bottom line is, suicidal contracts are still considered standard of care. So once we have done the assessment, what are the things to document? Document the risk level and the basis for the risk level, and also treatment plan for reducing this risk. This is the basics of documentation. Well, we need to document even more about the history, past history, things like that. However, despite our best efforts, suicides do occur, and the suicides do occur when the patients are in treatment. So what after a suicide? To facilitate the aftercare process, ensure that patient records are complete, be available for the family to assist in grieving. Especially in youth, it is important to debrief peers, teachers, school staff, and also it is important to let them know the help is available. There are counseling services, and also remember, medical record is still official and it is still confidential. You cannot kind of go ahead and discuss with the media or something like that. And seek support from your colleagues, your supervisors. Always, always, always consult your risk managers. So it's kind of a slide of a little bit of a recap. So we assess for psychiatric illnesses, we assess for the history, prior histories, prior suicide attempts, family history, medical diagnosis, individual strengths, vulnerabilities, psychosocial situations, suicidality and symptoms. And these are my references. And actually, as Dr. Guman was saying, I did not include my research slides because the only reason is I did not get at the complete conclusion yet. It's still in work in progress, so I did not include those slides in the presentation today. Any questions?
You mentioned about the one study where communication with father is important.
Mm-hmm.
Is that, I mean, did they look at for both male and females? They tried separately?
In that study, I looked at the paper, but it was actually to repeat the question. So in the study where it showed communication with the father is important, failure to communicate with the father is a risk factor, whether they looked at both male, like both father and mother. In that study, actually, for some reason, they did not look at the mother, actually. They looked at the importance of the father. I think this is a study done on African-American population where they looked at absence of father or having any relation with the father at all. So.
I mean, was it good for both male and female children?
Yes, yes, it was.
Two questions. On the first one, you had smothering as the second largest cause in most of those groups. Did that include hanging, I'm imagining?
Yes.
Okay.
Yes. The question is, did the on the suicide methods, when it mentioned suffocation, was hanging included? Yes.
My other question is just the general results. What is the difference, the biggest difference in risk assessment between a pediatric population and an adult population when looking for suicidality?
That's a very good question. So the question is, what is the difference while assessing adults versus to youth in terms of suicidality? So we have to remember, I mean, there are multiple factors in that. So to kind of like name a few, you can see most of the kids, they don't, like while you're assessing for suicide, they don't want to go to the hospital. If they knew that they're going to the hospital, they're going to deny it. Collateral information is available on the kids, no matter what. I mean, even if they're in a foster care, there is information available. If they live with parents, they live like elsewhere in group homes, there is always collateral information available about the behaviors. So that's one good thing. With adults, it might not be available. So getting collateral information is available. And in terms of like, even while discharging patients from the ER, you can provide structure for children after, like they can be observed by the parents, they can be observed like by caregivers. So if there is a good support system outside and the risk of suicide is not that much, we can possibly discharge kids more often than adults. Yes, ma'am.
Did you know an adult completing suicide and whether those suicide contract, no suicide contract had any efficacy there?
So the data that I presented for, especially for the suicide contracts, it's also for adults too.
You're saying that there's no evidence for its working in both adults as well as in children. Is that
Right, that's correct, right. Thank you, everybody. And I want to extend my thanks to Dr. Jaswinder Guman and Dr. Brightburn, my fellows, for assisting me with the slides. Thank you very much.